So last time we had a little deviation from neurology. We were discussing differential diagnosis of a massive splenomegaly, because that's a common case, exam case, and also commonly not discussed very much. And to recapitulate that, for those who were not here last time, it helps, and also we'll conclude that and move on to other topics. Now, can you, somebody who attended, Anish is there, Prasanna, I can see is, yeah. So, Anish, can you tell the causes of massive splenomegaly? What's the size of when you say massive splenomegaly? What's the size you have in mind?
More than 12.
More than?
12 centimeters.
12, yeah. Always, as I said, never say 12 and stop. Yes. In the answering, you know. Any other answer? Prasanna? What did we say?
It crosses the umbilicus more than 4 finger breadths or more than 12 centimeters.
12. Okay. Of course, the books may vary. 8 centimeters, more than 8 centimeters. Up to 5, small. 5 to 8, moderate. More than 8 is massive splenomegaly. Okay. Can you, without looking into the book, can you tell me the causes, Prasanna? Causes, we are revising what we, causes of
massive splenomegaly or Kala-Azar.
Yeah, no, I will stop there, because in any place when you say the differential diagnosis or answer, that locality, what is the commonest, you must mention. Okay? Have you seen Kala-Azar here?
No, sir.
No. So you should not say that. But which is the patient you remember? Very large spleen. Pardon? Which
CML,
patient?
portal hypertension.
Yeah. So they're very important
CML.
in the way. Yeah. See, one of the things I am trying to do here in the classes is to how to answer the questions, you know. So don't start, if you are appearing in Patna, you know, for example, Bihar or Bhubaneswar in Orissa, you will be all right to say Kala-Azar, okay. So a commonness in the locality is an important thing. Okay, so can you revise the list and tell me 5?
CML, portal hypertension, lymphoma, polycythemia rubra vera, hairy cell leukemia.
Okay, fine. Yeah, at least if you are asked such a question, at least 5 causes you should be able to say without waiting. That means there are actually 10 causes you can say for splenomegaly, massive, of which can you revise the list a little and tell me, Anish?
Chronic myeloid leukemia. There is chronic malaria, Kala-Azar, then lymphoma, hairy cell leukemia, polycythemia vera rubra, then myelofibrosis, then tropical splenomegaly syndrome.
Yeah, okay. So what we can say here, the commonest thing we see here, malaria is not so common, but that is more in Indian situation, universal, better to bring it up in the higher in the list. Okay. So that is the one list which I think you can keep it. So the rule is the commonness. That's important. Then comes the hairy cell leukemia and all, not that common. So way down in the list. Gaucher's disease, things like that, which are less common. So more common, 5 causes, less common, another 5 causes. Okay. Each condition, we have said a few points as a revision, those who are not there. Yes, can you say, Prasanna? CML, how will you diagnose clinically? In a patient, you have big spleen, how will you consider CML?
Yes, sir. It depends on the clinical phases of CML. It could be a chronic phase, an accelerated phase, or a blast phase. In a chronic phase, there could just be a massive splenomegaly and a heaviness on the left upper abdomen. Whereas in accelerated phase, it is a transition into a crisis phase. And in a crisis phase, the patient could present with with symptoms of with severe anemia, neutropenia, or thrombocytopenia and bleeding manifestations.
Yeah, first thing you must say in the transition is the size of the spleen. In the accelerated phase, the spleen size starts rapidly increasing. Chronic phase, slowly increasing. So that's what you must say. Then you must say anemia comes, thrombocytopenia comes, lymphadenopathy comes. Lymphadenopathy you didn't say last in the answer. So blast crisis, they are more sick like an acute leukemia. Whereas chronic phase, only spleen, their hemoglobin is normal, platelets may be normal or higher normal. Okay. Now, Kala Azar. Anish, can you tell the salient findings? History and finding. Just the points, 1, 2, 3. Like.
There will be pallor, pyrexia, then palpable splenomegaly, then pigmentation, perioral pigmentation will be there.
Yeah, facial, perioral, or generalized. So that is enough actually. So 4 P's we said, pyrexia, pallor, pigmentation, palpable, massive splenomegaly. Okay. We are not discussing everything about Kala-Azar, just a few points. Now, malaria. Can you tell those who were there last time? Yes.
It usually presents with fever, chills, and rigors. There are 3 stages for malaria: the hot phase, cold phase, and the wet phase. In the cold phase, the patient feels chills. In the hot phase, the patient is febrile, and in the wet phase, there is profuse diaphoresis.
Yeah. So what you must say in malaria is that, are you staying in a place where malaria is common? Number. Endemicity. Residence and the second is travel to malarial prone areas. Third is the history of fever and chills, recurrent episodes. That is all. Otherwise, it will be only yes. In malaria, there are 2 ways of splenomegaly, representation with splenomegaly. Dhananjay, can you say what are the 2 ways? Dhananjay's light, you can adjust a little. Yes, no, better. I can see you better. Yeah. Malaria can present in two ways as far as spleen is concerned. Okay.
Chronic malaria and tropical splenomegaly syndrome.
Yeah, yeah. Chronic malaria is the endemic area, travel, recurrent episodes of fever with chills. And then can someone mention what we told about tropical splenomegaly? What is tropical? Rinoj, can you say what is tropical splenomegaly?
Fever is residing in tropical areas having fever plus splenomegaly and eosinophilia also.
Not eosinophilia is not a feature. We can use the speaker when you speak. Then I'll just come. Points in tropical splenomegaly. Do you remember the points? What is tropical splenomegaly?
Syndrome that characterized by massive splenomegaly in residents which was residents of the endemic areas of malaria, which is associated with the lymphocytic infiltration of the spleen.
Okay. So point-wise, you can say it is a manifestation of malaria seen in endemic area. Number 1 point, endemic. Second is it is an immune response. That's why another name is called hyper-responsive to malarial antigen. And third is a lymphocytic infiltration of the spleen. So it's an immune hyper-responsive to malarial antigen, recurrent exposure, endemic area, massive splenomegaly. Okay, that is then the complications of splenomegaly will be there associated. Okay. What about portal hypertension? Portal hypertension.
There will be ascites, splenomegaly, and dilated veins of the clinical features.
Yeah, little louder as a speaker.
There will be ascites, splenomegaly, and dilated veins over the abdomen, around the umbilicus.
Okay, okay. So we have to say that in a splenomegaly, what I look for is two groups of findings. One, signs of portal hypertension. Office splenomegaly is one. The two second and third signs are ascites and dilated veins. Other is, if it is due to liver disease, I will look for evidence of chronic liver dysfunction. Namely, can you say what are the evidences, what are the clinical findings for chronic liver cell failure or chronic liver cell dysfunction?
Ulnar erythema, spider maybe.
Yeah, one of the things I can suggest to you is that start from head to foot. Okay, then you will not, we will not head to foot. You are like examining the patient. What will be the main thing? Will be the hair.
Alopecia, temporal
Yeah.
wasting,
Yeah.
jaundice,
And parotid gland enlargement, bilateral parotitis.
Spider nevi.
What are the other causes of bilateral parotitis? The one is the liver, cirrhosis liver. Then bad oral hygiene, especially in diabetics. Then we have seen in calculopancreatic diabetes, more common parotitis. Then rare conditions like sarcoidosis. So parotid enlargement. Okay, fine. So you can come down like that. Here, after that, the eye icterus, you can say. Then coming down, spider nevi, gynecomastia, palmar leukonychia, palmar erythema, debutant's contracture. Then coming down, abdominal dilated veins, that's more of a portal hypertension. And then testicular atrophy, pedal edema, abdomen ascites, pedal edema. So head to foot is one way of remembering the findings. Okay, fine. Myelofibrosis, what is the clinical finding? So we will.
Severe pallor.
Yes, Prasanna.
Severe pallor, hepatomegaly, and chronic symptoms
Myelofibrosis, not hepatomegaly.
Splenomegaly.
Yeah, massive splenomegaly. Yeah.
And then when you
primary,
attempt,
the myelofibrosis can be primary myelofibrosis, secondary to some other diseases, and it's a chronic disease. So you have to say first it's a chronic disease. Okay, then pallor is and massive splenomegaly. That's all the finding. What other two investigative, or while you do the test?
A bone marrow aspiration yields a dry tap and teardrop cells in smear.
In the peripherals. Okay. An isocyte, especially teardrop. A target cell is not that common. Which disease do you get target cells at RBC?
Thalassemia.
More commonly?
Thalassemia.
Yes, yes, and liver disease, chronic liver disease. You can get target cell. This is teardrop cell, myelofibrosis. So we said we didn't discuss about the lymphoma. We will discuss how will you suspect in a patient with splenomegaly, clinically in your practice, what are the things you see? Is he pale or the opposite of pallor, more ruddy? But only in fair people you can make out that polycythemia. But when you look at the conjunctiva, you may get some feeling that it's more colored. So either the one extreme is pallor. So what condition? Myelofibrosis, hairy cell leukemias, all types of leukemias you will get pallor. Hypersplenism you can get pallor. Okay, any cause, any reason for splenomegaly. Whereas you must see is the hemoglobin normal clinically or anemic or polycythemic. Polycythemia is not as easy as anemia, but try and see. If they are polycythemic, then splenomegaly, the diagnosis is polycythemia vera. And often they have history of pruritus, especially after a bath, especially a hot water bath, pruritus, one symptom, but not that reliable. Okay. So polycythemia is one. Lymphoma, how will you diagnose? In a splenomegaly, you have to always look for lymphadenopathy. If lymphadenopathy is there, once only a certain group have got both lymph nodes and splenomegaly. Rinoj, can you tell a disease where spleen and lymph nodes?
Sir, I can't hear, sir. I can hear.
Did you hear? Did you hear the question?
No, sir.
Hello?
Hello, I didn't hear the question, sir.
Can you hear me?
Yeah. Now I can hear.
Rinoj's connection is. Yes. Maybe somebody else can answer while Rinoj gets the connection clear.
Lymphoma, CML,
Hodgkin lymphoma.
Now you can hear me? I was telling about, so when you have a splenomegaly patient, you look for anemia, polycythemia, you look for liver cell failure signs, portal hypertension signs, and we were talking about lymphadenopathy. So what disease? You will get lymphadenopathy and splenomegaly.
lymphoma, CML,
Think there was some problem in the connection. We were talking about lymph nodes and spleen. What are the conditions? What are the? Can you tell, Rinoj?
Not Hodgkin's lymphoma, Burkitt's lymphoma.
Yeah. So you must say lymphoma first. Okay. So in lymphoma, the common Burkitt's don't mention here because it's not common. So you must, what are the common lymphomas you see here?
Non-Hodgkin's lymphoma and Hodgkin's lymphoma.
And Hodgkin's. Hodgkin's lymphoma, younger patients, better prognosis, and non-Hodgkin, that classification would be enough. So lymph nodes, what are the characteristics of the lymph nodes? Dhanujay, characteristics of the lymph nodes in a lymphoma. Clinically, when you feel it. Little louder speaker you can, and the light also you can. Yeah, you can. What character, when you feel it, examine what will be the character.
Rubbery.
Yes, okay.
Painless.
Is it painless? Yes, painless. Rubbery. Is it matted? What do you think? Anish, is it matted? Matted is in matted lymph nodes in which condition?
TB, tuberculosis.
Tuberculosis.
What is the reason for the matting?
Necrosis.
Perilymphadenitis.
Yeah, perilymph. And so the capsule also gets involved, and so they stick together. That's all it means. Whereas lymphoma, there is no the peripheral part of the node is not. It is that lymphatic inside part of the lymph node which is involved in the abnormal. That's why the lymphoma nodes are discrete. So what I'm trying to give is points like in lymphoma. What are the things? It's discrete, that means not matted. It is non-tender, soft, or rubbery, mobile. They are not fixed to the adjoining tissues. What condition do you get a fixed lymph node?
Carcinoma.
Malignancy, no? Cancer. Carcinoma, secondary deposits, they get more fixed to the. So this is how you have to get the points one below the other. So the lymph nodes are discrete, rubbery, mobile, non-tender. Okay, tender nodes are more common in septic adenitis, more inflammation. Okay, so what you learn, how to study the clinical thing would be in points. Like we were saying, Kala Azar, these are the points. So that should be the way you have to, in the examination also, to answer. Okay. So we will conclude the splenomegaly part of it. That is, when you have a patient with splenomegaly, the way you start presenting either to the consultant here or in the exam is that I would like to discuss the differential diagnosis in this patient. That's the first thing to say, because you don't have a straight diagnosis in most of the cases of splenomegaly. So I would like to, then you say, first I would like to consider portal hypertension, because that's a common thing. Due to extrahepatic cause or hepatic cause. And what are the common hepatic causes of portal hypertension? Yes, Anish, you can say.
Schistosomiasis, cirrhosis,
No.
alcoholic.
Again, the same mistake comes. That is very rare disease. Always you must think, what have I seen in the last 2 years, 3 years? Never say schistosome, because we don't see it here. So you have to get into that practice. When a question is asked, you have to think, what have I seen? What's a common here? Now can you revise? Common
Cirrhosis.
cause.
Chronic liver disease.
Yeah.
Chronic liver
Anish
disease.
can,
Chronic
Anish
liver
can
disease,
complete it. Yeah.
chronic liver disease, alcoholic hepatitis, then schistosomiasis.
Schistosomiasis not common, so don't mention here. I
Bacteria
would say,
But-
pardon?
Bacteria.
Yeah, that is even a little rarer. I think the
Portal thrombosis.
cirrhosis liver, alcoholic or post-hepatitis, post-viral hepatitis. That's a common thing we see. Third is cryptogenic. Then fourth is non-alcoholic fatty liver. Fatty liver causing cirrhosis in the later stages. So non-alcoholic fatty liver producing cirrhosis. Okay. So in other words, alcohol, post-viral, non-alcoholic or fatty liver producing cirrhosis liver, those are more common then of course rarer conditions. Cryptogenic, where the etiology is not Then, of course, Wilson's disease, and because in this area, schistosomiasis is not common. So this you have to get practice it. Common things, I must have the list of 5 conditions in most of the things if you can. Okay. So you have to say, I consider portal hypertension, and I look for other signs of portal hypertension, namely dilated veins and ascites, but this patient does not have those findings. So that is finished. Then you have to say, I considered if a patient is anemic, myelofibrosis, as patient is severely anemic. I considered polycythemia because the patient's hemoglobin seems to be clinically elevated. Ruddy polycythemic appearance. I'm saying how to go. I considered Kala-Azar. However, this patient does not have pallor, history of pyrexia, pallor, or nor pigmentation. You understand how to say it? You have to mention the condition, the findings which are present, but findings also which are absent. Okay. Is that clear? That's how you discuss in any patient. It mention the condition, say the findings in favor, and say the findings against it. Okay? So I think we will conclude this topic of splenomegaly, large spleen, massive splenomegaly. That is, of course, we will revisit it later, but it is something which you can make a list. All this, according to the commonness, make a list. That's the most important thing. Okay. Now I'll ask you some questions. Like, what are the causes of nerve thickening, Prasanna? What are the causes of
Hansen's disease, amyloidosis Refsum's disease?
So are you telling the common diseases? Hansen, yes, right. You have started right. So are there more common? Because besides Hansen, nerve thickening is not that common. So rare diseases do come in. Okay. Can you say more? Some more condition, about 5 conditions at least. Hansen's. Anybody else would like to contribute in the list? Nerve thickening. Raynaud's light, you don't have Raynaud's?
Current cone, sir.
Ah, yes, sir. So we can barely see you. That is fine. Yes, Dhananjay, do you want to, anybody wants to enlarge the list of nerve thickening? So Prasanna said Hansen's, amyloid, Refsum's. Okay. Any other? So, okay. Or actually other conditions are rare. CIDP, can you get nerve thickening? CIDP? Yes. What is onion bulb appearance in pathology? Onion bulb appearance.
Intermittent nerve thickening.
Pardon? Yes. Anybody can. Onion
Iodination
bulb.
and
When you take a section of the nerve, it looks like onion. If you cut the onion, the layers, you know. That is why it is called onion bulb, which is found in conditions with nerve thickening like CIDP. The relapsing type, particularly CIDP, can a progressive type or a relapsing type. In the relapsing type, you get onion bulb appearance. What is the reason? Demyelination, remyelination. Okay, it happens several times. You will find one layer of myelin is gone. Then after some time, that area will be like a fibrosed. And then another layer of myelin deposited. Then another layer, recurrent episodes, relapsing type. Or CIDP is one other condition, okay? Then there is another condition, you can make a note of it, hypertrophic polyneuropathy of digerin and sota. Hypertrophic polyneuropathy of digerin and sota. SOTTA, digerin, DEJERINE, digerin. So can we say the list again? You must start with Hansen's. Still, that is one of the causes. Then you can say CIDP. We see more CIDP. Then we can say refsums. What are the other components of refsum, Dhanijay? Each condition you must remember points. Anybody knows the refsum? What are the clinical findings? Just points. One is nerve thickening. Ichthyosis, dry skin, retinitis pigmentosa, and nerve thickening with peripheral neuropathy. Okay? Three findings. So like that, you have to get on to all conditions. Can you tell me, can you tell the whole list now, Prasanna? You have started.
Hansen's disease, CIDP,
Yes.
Refsum's disease, amyloid, and digerin and sota. Hypertrophic polyneuropathy.
Hypertrophic polyneuropathy of digerin. I think that would be fine. If you can manage three conditions, and that would be fine for the exam purposes. In the common practice purpose, we have seen Hansen's, and then CIDP also. We have not found too many patients with the nerve thickening, but that's a condition weak. Okay, I'll ask another question. What are the causes of arachnoiditis? So that's one differential diagnosis in clinical diagnosis condition in clinical practice and exam. What are the causes of arachnoiditis?
TB.
Yes, number one, there should be that. Any other cause anybody knows? I think the other causes are rare. Here almost always it is TB. Other is syphilis, which is not a common thing now. And the third is recurrent lumbar puncture due to for surgery, or olden days we used to give intrathecal steroid and streptomycin. That was one of the causes. But now we can say two major causes are, actually one major is tuberculosis, syphilis, repeated intrathecal administration of drugs. Three causes, okay? So like that, you have to make a list. That's my idea of discussing this type of question. Now, what is the clinical presentation which is highly suggestive of arachnoiditis? How do they present?
Headache.
No, you have to imagine before you answer. One thing I suggest you, imagine the pathology and look at the situation in your mind before you say the answer. That should be, that's why in MBBS, you remember, we did anatomy, physiology, pathology. And then only we really go into clinical, mainly because the thinking also has to be like, where is the arachnoid? It's the covering of the spinal cord, pia and arachnoid. So when you, in your mind, when you say arachnoid, what happens to the arachnoid in arachnoiditis? Yes, Dhananjay, can you imagine? How will it look like? How will it feel like if you touch the arachnoiditis? Spinal cord, for example, spinal cord is the common place. That's a way to answer, not really. So when you think of the pathology, the appearance and what happens, then it's easy for us to deduct the findings, history and finding. Okay, how will, what will be the appearance of the arachnoiditis? Arachnoid in arachnoiditis. It's usually chronic arachnoiditis. Yes.
Thickened.
Yeah, Prasanna, yes, you want to say?
Thickened.
Thicken, yeah. So because of this smoldering inflammation, if you touch the spinal cord, it should be so soft, the pia and arachnoid. Whereas if you touch the arachnoid, it will be like touching a thick leather. You know, it is so thickened, it is firm. And how does arachnoid look like? I wish we had a specimen. It is not an thickening which is so uniform. It is sort of smoldering chronic inflammation. It's sort of in some areas more thick, some areas less thick. In between, some areas are skipped. You know, this type of irregular thickening of the. So what happens to the spinal cord? When the arachnoid becomes thick over a few months or years, a few months to year, what will happen to the spinal cord? That's how you have to learn. What will happen? Yes, Rinoj, you little louder. Yeah.
Spinal cord can be injured, touched.
Yeah, I would say like this. The spinal cord is compressed by the thickening all around it, you know, isn't it? So the roots are caught in the thickening, radiculopathy, and spinal cord is compressed from as if you are putting a tight belt on the spinal cord and screwing it. That's how it is. So it is what is the clinical presentation, Anish? Arachnoiditis. What type of myelopathy we can call it?
Compressive
Compressive myelopathy. That is the important thing. Non-compressive myelopathy can be compressive or non-compressive. In the compressive myelopathy, you have tumors, arachnoiditis, and tumors, granulomas, secondaries, etc. And of course, sometimes disc prolapse, central disc prolapse. Non-compressive myelopathy is subacute combined degeneration. Example, you know. you can get. So that is how you, now you, if I ask you, now the presentation will be, it will they present like a chronic arachnoiditis, present like a chronic subacute or chronic progressive compressive myelopathy, which can involve the cord and the roots, because the arachnoid can also catch the roots. So what you will, because the roots are affected, what will happen? Clinical finding? Prasanna?
Radiculopathy.
Yeah, what will be the finding? Compression means there will be UMN signs below the area of compression. Radiculopathy means what will happen to some reflexes, some areas, when according to the root, if it is roots are not involved, it will be a UMN signs, compression of the pyramidal tracts. When you get a combination of roots, and it's called radiculomyelopathy. How do you know the root is involved? Root pain may be there. Root compression, segmental, localized, wasting, weakness, and loss of reflexes. LMN signs will be there. You understand? That's how you. The second characteristic of arachnoiditis is multiple levels. What do you mean by multiple level? I was telling you, the pathology is a chronic smoldering, irregular inflammation and thickening. So it is not a uniform thickening like a mass, pressure. It is an irregular. That's why in some left side, when you say below T10, the sensory is lost. But the opposite side, that area is not affected. On opposite side, sometimes L1, L3, L1 to L4 will be affected. If you find such multiple levels in sensory particularly, and in multiple levels you get root involvement. So root plus cord involvement, multiple levels, if you can make a note of that, are suggestive. First of all, arachnoiditis is a compressive myelopathy. Second, it can involve cord and root. Third, multiple levels of sensory or motor are suggestive of arachnoiditis. Okay? So what are the causes of subacute combined degeneration? Who would like to? Dhananjay can. Causes of subacute combined degeneration. Is Dhananjay here? Or any of you can? Yeah. Yes, Rinaj, yeah. Subacute combined degeneration. Not audible. You can unmute.
Vitamin B12 deficiency, acute vitamin E deficiency, then syphilis.
No. First answer is correct. Okay. Prasanna?
I know about vitamin
Anish?
B12 only.
Only. There are 3 causes, in fact 4 causes of subacute combined degeneration. One is, of course, the most common majority B12 deficiency. Then hypocupremic, that is copper deficiency. folate deficiency. Exposure to nitric oxide, chronic exposure, laughing gas. Some people, because it is they want to laugh, they will smell some nitrous oxide in between. If you can't laugh, that is a good way, but don't do it. You may get subacute combined degeneration in the long run, just to remember. Okay, now you can say B12 deficiency, folate deficiency, copper deficiency, toxic effect of nitrous oxide chronic exposure. Okay, I'm asking a few questions so that you can make a list of the answers. Okay, now last of the question will be parietal lobe signs. Parietal lobe signs. Okay, Anish, want to start? What are the signs of the parietal lobe involvement?
Sensory cortex is involved. Then cortical sensations are involved.
Yeah, you have to
Motor
answer.
cortex is involved.
Dyscalculia.
You have to answer better your formulation of answer. You have to say that cortical sensory loss due to involvement of the sensory cortex. Okay? That's how you have to say. Number one. Okay? What did you say?
Agraphia with alexia.
Agraphia, yeah.
With alexia.
No, cortical sensation you can explain. You can say cortical sensations, namely graphesthesia, stereognosis, 2-point discrimination, tactile localization, sensory inattention. Do you know what is sensory inattention?
They can identify
Sensory.
individually. If we touch individual hand, they can identify, but at the same time, they will localize to the side of patient.
They will miss on the
Side of lesion. Opposite side of
okay, okay. Okay. So when the parietal lobe is involved, individually, if you suppose you touch the patient's body, individually they are able to appreciate. But simultaneously, if you touch, that tactile localization is missed on the affected side. Okay, that is called sensory inattention. Okay, then there are a few other, you can make a note of it, is a right to left disorientation, unilateral neglect of the affected side. They say, I have no problem on this side. That's the side which is affected, but they neglect it. One more word I will introduce, alesthesia, A-L-L-E-S, alesthesia is the misplaced localization of a tactile stimulus. That means if you touch on one place, the patient will show another place actually. Whereas an intact parietal lobe, actual tactile localization, good 2-point discrimination. Whereas alesthesia means misplaced. They feel there is the touch, but they will show it in some other area. Misplaced localization of a tactile stimulus. So these are actually some of the, so at least what you must say is that cortical sensory loss, namely, you can use that word, namely graphesthesia, stereognosis, and 2-point discrimination, loss of 2-point discrimination. That is sensory, cortical sensory. Then you can say sensory inattention. Then you can say right to left disorientation, unilateral neglect and alesthesia on the affected side. Okay, I think what we were trying to do is, of course, finishing this splenomegaly as a deviation from neurology. All neurology, you will get fed up with neurology. Tomorrow also we'll have some neurology. Nikhil will be taking. What I am trying to do also, you would have realized that how to, we didn't see any of our newer students. Anish, what happened?
I informed